Good evening, everybody. I'm Dr. Rick Lehman in St. Louis. This is In Your Corner with CORA, 9/22/2020, and we're talking about football injuries. And really, one of the most common things you see, especially if you've been a sideline doctor, are burners and stingers. Athlete comes off the field, shaking their arm, maybe took a bad hit, and it's something we see not infrequently. So starting off, I like our cast to introduce themselves, and we have actually a very, very good group tonight, so this should be a very interesting topic, starting with Dr. McGarry. Dr. McGarry, go ahead and introduce yourself.
Thank you, Dr. Lehman. My name is Dr. Tim McGarry. I'm an orthopedic surgeon. I do basically general orthopedic surgeons, but specialized in sports medicine, and my practice is down here in Bristol, Virginia.
Bryan, give it a ride.
My name is Bryan Anderson. I'm the Director of Sports Medicine and Community Outreach for CORA. I've been a certified athletic trainer since 2004, really covering all sports, but various levels of football, and have definitely seen my share of stingers and burners.
Charles, go ahead and introduce yourself, buddy.
Yeah, Charles Peters. I'm a physical therapist, senior clinic manager, Elizabeth in Tennessee and Tri-Cities area. So I've been practicing for about 7 years with in the clinic and then for sideline sports coverage as well.
That's great. Everybody, thank you for participating tonight. We're going to jump right in. Dr. McGarry, maybe you want to lead off here and tell us exactly what a burner or a stinger is, and explain what that term means and how we use that term.
Sure. As you mentioned, obviously it's a fairly common injury we see. Basically, sort of the technical term when you see this is basically a sort of neuropathic brachial plexopathy. And basically what that means is that what happens, sort of the pathoanatomy of this, is that you sustain a stress injury to the brachial plexus. It's an injury we see mainly in football, but occasionally you can see it in wrestling. I've seen it in a soccer goalie before that basically went to dive for a ball and hit into the goal post. But basically what happens to the mechanism of injury is you have a sort of a downward pressure on the shoulder, and then an extension injury where the head is driven to the other way. And basically what that does, it stretches the brachial plexus. It's basically the term stinger or burner is a very descriptive term because that's basically what people describe. It's almost as if your arm kind of tingles and goes numb. Classically, you'll see a player come off the field after an injury like this, and either they'll be holding their arm down to their side or basically they're shaking their arm. Much the sort of the injury much more commonly seen in like DBs and defensive players that basically go in to tackle somebody, where the opposing player hits them at sort of the side of the neck, causes their ipsilateral shoulder to go down and their head to go the other way, and that basically puts a stretch on those nerves, and it gives that kind of nerve tingling, kind of burning, stinging sensation in the arm.
That's excellent. You know, that's exactly right. It basically is a stretch injury, commonly seen at C5-6, but a brachial plexus injury. And again, you're right. I mean, it's something we see sideline guys all the time. So Bryan, you're up, buddy. So you're on the sidelines, you're covering a football game. Athlete comes off, just like Dr. McGarry says, shaking their arm is kind of a little bit limp at their side. Give us your assessment, and what are the questions you're going to ask the athlete? How are you going to assess the athlete? And what does your physical exam look like?
I mean, the first thing we're going to do is rule out any serious neck injuries, right? So anything that would give us a medical emergency or something that we need to spine board or send to the ER right away. Anytime you have somebody complaining of numbness or tingling in one arm, that's what we get worried about. Generally, you know, it all starts with the history, what's going on. And like Doc said, they're generally going to tell you, the one I get most of the time is that I got lightning shooting out of my fingertips, or I can't feel my arm, or, you know, it's weak. Move to palpation, obviously going to palpate neck, cervical spine. And then moving into that kind of anterior lateral neck and down through the shoulder girdle to the shoulder. We want to rule out things like shoulder dislocations, clavicle fractures, as well. And then generally, we want to know how bad is that actual nervous injury. So we want to check upper extremity dermatomes and myotomes, and kind of see where they are. So again, that's a basic sideline kind of evaluation.
And when the athlete comes off and they've got this typical prototypical burning, dead arm syndrome, maybe tingling in their fingers, is there anything you can do? What do you normally do to try to relieve some of the symptoms?
Generally, I'll get some ice kind of on the area and try to get things calmed down. The other thing you can do is, again, kind of have them sit with what we call a good posture. Definitely, we don't want to stretch the area at all, but have them sit kind of open-chested, shoulders back, so we can take any other stress potentially off the area. What we tend to see with football players, especially, is what they kind of want to do is hunch over and relax, or they want to sit on the bench and kind of collapse like prima donnas, right? And again, we want a happy medium in that, so we're not putting any more stretch on that brachial plexus or in the surrounding musculature that might be fired up or guarding at that time.
That's excellent. And I agree with that. I think that chest out posture really helps open up the neural frame a little bit and hopefully calms them down a little bit. And you mentioned something that I think is important, especially for the trainers and PTATCs. You talked about the differential diagnosis a little bit, and that's right, clavicle fractures, just shoulder dislocations, AC joint injuries. When do you want to transport that patient? When do you turn to the coach and say, hey, you know, we're going to the emergency room or calling over the EMS? When do you feel that athlete needs to be transported?
So generally, there's a couple things we look for. Any severe guarding or pain in your anterior or posterior spine, or your cervical spine. If you have numbness and tingling down both arms or going into one lower extremity, it's automatically a medical emergency. Stabilize head and spine and wait for EMS, get them on a spine board and take care of them. And the other thing, I taught this for a little while in a university, and the other thing I would tell my students is trust your gut as well. You'll get some of these things and you're like, that's not a stinger. You know, there's just something about it that either their emotions a little restricted or they're super guarded or they're, you know, just very protective of it. And I always say, trust your gut in that case. Moving forward, again, if your symptoms aren't going away, generally with a stinger or a burner, 20, 30 minutes of symptoms, and they should be resolving again as we rest and everything. If symptoms are continuing or worsening, obviously it necessitates a medical emergency.
So let me ask you a question. I'm a DB. I made a tackle. I come running off. My arm's numb. I say to you, Bryan, this has happened to me 5 times, and I'm ready to go back in the game. What's your assessment of that? And then what's your assessment of when the athlete can go back to play? You haven't talked to the doctor. The athlete is raring to go back, says he's had it before. What are your parameters for letting that athlete go back?
And kind of mine specifically, I look at how many times has it happened. Is it like you talked about, if it's 5 times in a game or even in that week, they're done. And they're probably done before they get to 5 if I know about it. Generally, what I look at for ready to go back is strength. Is strength normal bilaterally? Is it normal what they should be able to do? Again, neck range of motion. Is there anything that's going to cause it to come back? Are they super guarded in their anterior neck and their chest and their pecs? That's going to kind of cause that stretch and that inflammation. But again, if I have a guy that has 1, symptoms go away, strength is normal, and I send them back out on the field and it happens again, they're probably done, and they're on their way to see a doc Monday, if not sooner. But again, I'm pretty conservative with some of this stuff. I don't want to miss this and have a serious nervous injury or something, you know, extremely long lasting.
That's a good question. And I agree with Brian's answer. You know, if I see a player that gets 2 stingers in one game, by all means, that player is going to be out. Because obviously the one thing you're concerned about is there some kind of congenital anomaly that's predisposing to having these recurrent stingers? You know, I think Brian hits the nail on the head. You know, you can get, you know, Charlie horses and bruises and stuff. When you're getting numbness and tingling, that obviously raises the specter that that's something you need to take a little bit more seriously. And 2 injuries or 2 accidents like that in the same event or same game definitely raises the level of suspicion. The other thing that Brian touched on was, again, it's sometimes difficult on the sideline because invariably, you know, especially football players are going to come out and they're going to say, listen, is the numbness gone? There's a yes, it's gone. I want to go back into play. So it's very important to make sure your neurological exam is to the point, it's well structured and documented, that you make sure that they've got strength equal to both sides. They've got full range of motion of their neck. They've got no residual numbness that you can ascertain, that there's no real difference in even their deep tendon reflexes in their biceps and their triceps, upper extremities. So when I see the kid in the office that following morning, that's the first thing I would do is try to do a very thorough neurological exam, make sure they are back to baseline again. And then if there's even 2 episodes, I have a low threshold for go ahead and passing that player on to get a little further test. The first time I would probably do EMG studies are kind of low yield, especially after the injury is resolved. But I think one of the most important tests would be an MRI, because the thing I'm more concerned about is some kind of congenital, either shortening of the pedicles or congenital spinal stenosis that would predispose a player to not only the recurrent stingers, but the more serious extent of some kind of catastrophic neck injury. And then you're talking about paralysis and issues that you don't even want to talk about in any kind of athlete. So at that point, I would make sure their neurological exam is normal, but I would, again, have a low threshold for putting that player on to get a little further test. And I think the first thing I would consider doing is getting an MRI of their cervical spine. I would, that's a great question. And I think that as a baseline treatment, I would definitely, with the injury like that, the first thing I would do in my office would get plain x-rays. Sort of the neurosurgeons consider doing a lot of things with flexion extension x-rays. I don't really do that too much in my office because I don't know how much yield that's going to give for me, but just plain x-rays in the office, which you can tell obviously if there's anything on a catastrophic event that's gone on, like a jump facet or something like that. Obviously, you want to rule out any kind of bad, significant congenital anomalies. But again, if you're worried more about some kind of intradiscal pathology or even MRI to be able to figure out exactly the canal circumference, like I said, the next thing I would consider doing would be an MRI. The thing is just sort of an anatomical variant. There's been several high-level athletes who basically have had this diagnosis. But basically, the same kind of thing is if you're thinking of sort of the pathoanatomy of the injury, where you're getting a downward force on the ipsilateral shoulder and then an extension force on the neck, obviously through the neural foramen run all the nerve roots. And now, if the foramen is congenitally small, then obviously you're going to have a less room for error, and you got more predisposition to any kind of significant stretch injury. You don't have as much room for the nerves to be able to sort of accommodate that injury. So those folks that have the congenital anomalies are sort of predisposed to having more significant injuries and having symptoms with a lot of less force. So those are the kids you really need to rule out. And again, those are the kids that, it's not, economically feasible to get MRIs on everybody. And so those kids that come into me, like I said, that's sort of red flag raised to me. If they've had multiple stingers, then that's the group I'm going to say, listen, this might turn out normal, and everybody hopes it's going to be normal. But any type of recurrent symptoms, obviously, that's something you want to make sure you rule out, just to make sure there's no significant risk that player is going to have something catastrophic happen. So that's the red flag. That's what triggers to me is multiple stingers, that we need to make sure that the anatomy is such that the kids are safe to go back and they're not going to put themselves at significant risk for significant neck injuries.
Oh, I agree with that. So you made the diagnosis. Let's say their MRI is okay. Like you said, you hope it's okay. And they've had 3 episodes over a 2-month period or 3-month period, beginning of camp all the way to playing. How are you going to treat that athlete? What's the treatment protocol, and what do you do to treat that athlete?
Well, one thing right off the bat, that's where I reach out to my CORA colleagues. I think that's a very important aspect now, to get those kids over to physical therapy, get them some evaluation by a professional there as far as getting them into some exercises, some things they can do to try to help to support their neck and try to minimize their symptoms. Otherwise, obviously, they're basic things, and this branches more to the realm of the coaches that obviously, they talk about, seeing what you hit. Make sure you don't lead with your head. Football on every different level has come a long way in the last several years as far as mandating things like that are much more protective as far as protecting neck injuries and trying to avoid any kind of catastrophic life-changing events. But again, proper sports technique is very, very important. There's some, I routinely, if I see a player that has one, even more, I will definitely right off the bat, will sort of work on changing their equipment in the form of either a neck roll or a cowboy collar or a spider pad underneath their shoulder pads, just to be able to, again, that's just sort of a kind of protective way to keep the neck in a better position to sort of avoid that type of mechanism of injury that we're looking at. But I think that there's no question, if I see somebody that's got multiple injuries, I definitely would enroll them in a course of physical therapy to do some things to try to rehab that player with a long-term goal of making sure they don't have repetitive injuries.
That was excellent. That was very, very good information, Dr. McGarry. So Charles, Dr. McGarry saw the patient. The patient's had 2 or 3 episodes, and now sends him over to you for physical therapy. Give us your thoughts, your evaluation, your treatment plan, and how we're going to treat this athlete after multiple episodes, or even maybe one episode where he's had some type of brachial plexopathy, a stretch injury, or some trauma leading up to burning, dead arm syndrome, tingling and numbness, and possibly a little residual neck pain.
Yeah, so a majority of those stingers, your duration is between about 2 to 10 minutes, and then so if they're having those lasting symptoms and they get to me at my point, that's a point where we have to look at a few things if it's already been cleared. So they're still looking, probably experiencing possibly some altered sensation and some weakness, maybe even a little range of motion deficit. So our first goal is make sure we keep the passive range of motion within the shoulder, assuming that the neck has been cleared from a range of motion standpoint. And then I'm assessing, if it's, grip strength overall, that's a factor. If it runs all the way downstream from grip to elbow and shoulder function, a lot of times, again, we talked about that common C5 and C6, they're going to be weak with shoulder abduction and external rotation, so that where they come off the field and that shoulder tucked in by its side, we're going to work with shoulder stabilization, external rotation, and abduction, because that's going to be that weak point on that plexus. So we go right off with, again, a lot of, I would say passive motion. Initially, just assess the joint, make sure it's clear, working on, again, not necessarily aggravating that area. Again, because like I said, the majority of these have resolved. So if we're seeing them, we want to work with general rotator cuff stability and endurance with lifting out to the side and flex, because that's normally that position they'll be in that mimics either wrestling or football.
Is there anything else you can do strength-wise that's going to benefit somebody who comes in who's had repetitive burners or stingers from a strength parameter viewpoint, i.e., you talked about the rotator cuff a little bit. Is there something to do in conjunction with wearing a neck roll, maybe changing the shoulder pads a little bit more cervical spine support that's going to limit the number or the stress, as Dr. McGarry has as well put it, the traction stress into the cervical spine?
Yeah, also, so a factor in that could be possibly the scalenes where the plexus is exiting out. You see either some hypertrophy or you'll see some irritation in the area. So we also, at my level, we want to make sure that those scalenes, again, which they're not maybe contributing too much, again, maybe calm those down if they're muscle spasm, and then also strengthen those up as well. He mentioned, maybe limiting extension and rotation or the side bending component with the cowboy collar, also a good thing you do. So you'll get some of these individuals, once you have that trauma to the head and neck area or the shoulder, you want to assess, not just focus on the shoulder, but neck as well. So this could be isometrics as well as some general movements that'll work keeping the really head upright.
I think acutely, I think Brian's hit on this note a little bit. I'll let them go back in the middle of a game if they are completely asymptomatic with a normal exam. If their numbness is gone, they've got full range of motion, no pain, and full strength, I'll let them go back. Now, if I see that same athlete in the office with multiple injuries, at that point, obviously they've got to have a normal exam. But if we're going to get to the point we're going to rely on further testing, in particular specialized radiographic testing like MRIs, then obviously that test has to be normal. Now, there's obviously gray areas like anything where, if an athlete comes in and their MRI is sort of in between, it's not completely normal, but there's no significant impingement or stenotic lesions. And then again, it's like a lot of things in sports medicine and taking care of athletes, where you have to sit down, talk to the family, talk to the athlete, say, listen, here's our chance, here's what we're dealing with. Your neck is not completely 100% normal. It's not abnormal. I think if we can get you rehab, we get you an appropriate new gear, new kind of a protective equipment, cowboy collar, neck roll or something, and your symptoms stay under control, I think it's safe to do. But again, it's like a lot of things where you just have to sit down with the athlete, take every case individually, associate the parents, obviously, the whole situation, the whole family, and then the coaches too, to be able to get everybody on the same page of music, get the athlete as optimized as possible, and then go from there. Well, that's a tough question. And it's almost the hardest question. People say, well, what would you do? And again, it's one of those things that I would sit down and say, listen, obviously your son has had 2 injuries, okay? His exam is normal now. We've got the benefit of the MRI. The MRI looks good. We're going to put your son through an exhaustive physical therapy program. We're going to give him new specialized equipment to protect this. But unfortunately, there's no such thing as guarantees. We can't say that. But obviously, I see kids all the time that get injured a whole lot of different ways in football, more catastrophic injuries and bicycle wrecks and motorcycles. So again, you got to understand the risks. And ultimately, at the end of the day, it's your decision. I can tell you that, to the best of our knowledge now, your child is at as optimized a position as possible, that it's safe. But, if you're looking to try to get 100% assured, guarantee that nothing's going to happen, we can't do that. But again, we can take every precaution we can. We've got the test that the anatomy is not something that's going to put your child at increased risk. We're going to get your child rehab. We're getting the appropriate equipment. And then I think that all things considered, I think it's potentially a safe situation, as safe as it would be for any other player out there on the field.
Bryan, we're going to toss the ball to you for a minute. Dr. McGarry clears him to play. Athlete shows up, standing on the sidelines. What are you going to tell the coach? You're just going to tell the coach, okay, he's been cleared to play. You can evaluate him. What's your input? And how do you counsel the coach as to when this athlete should go back?
Just like with anything else, I'm a big believer in kind of a graded return to play for just about everything. It's something we toss around a lot with concussions, but I think it increases our level of safety and assuredness with every injury. So, one of the things we talk about or think about with stingers and head and neck injuries in particular is we think about our head, as a golf ball sitting on a tee. So I want to know that that's stable. So I want to strap a helmet on it and add a couple pounds worth of weight and have them move around and just kind of see how they accept that and see how they kind of take that. Make sure the neck's not getting tight or sore or they're getting some symptoms back. Next thing I'm going to do is I'm going to have them, maybe do some bag drills and kind of just some form up kind of tackling stuff. And again, see how they respond and see how things are going. I'd love to say I could trust my athletes subjectively 100% of the time, but I'm probably going to do some strength testing throughout these drills to make sure that we're not getting, any return symptoms. And then again, gradually return to maybe some form tackling or some butt up kind of tackling on a player. And for two purposes. Number one, we want to test and see how they respond, but I also want to know they know how to tackle. I mean, Doc talked about it a little bit before, but one of the leading cause of these injuries is poor tackling. So again, I want to know that they know how to actually perform a proper football tackle without leading to injury. And again, if we can get them through that in a day, 2 days, and kind of let them work back into normal play, then that's what we'll let them do. Most coaches will hate that decision, but I always tell them, like, look, we can take a couple days to get him back, or we can put him out there right now. He's not ready, and you lose him for the rest of the season. So again, sacrifice a couple days and let us make sure he's okay.
Charles, why don't you give us a pearl or two for closing thoughts on burners and stingers, anything we left out, anything we should have added?
Yeah, so with those kids, you want them to be in a protected position. You'll get a few guys that say, "Hey, I can go right back out there," but they can't lift their arm up to protect themselves or perform a movement common to the game. So that's where that strength testing, the range of motion, the sport-specific drill is good, because you'll get some of these kids that are real tough, and then you'll get some on the opposite end of the spectrum, but you have to protect them first. Again, whether that be make sure they have adequate motion and strength needed to perform at least the minimum amount necessary. So that's all we're looking for. We'll make sure the neck's good, make sure the shoulder function is impaired, and then touch up with equipment as needed. If there is, a congenital defect or something that's altered, that's the reason why we look at this, because we could save somebody's life in a deeper way if it comes to that. And that's ultimately, our responsibility to screen that and then worry about the sports side of it a little later if that comes too. So kind of the do no harm, but always protect them as well as the best we can. So that's kind of what we aim to do.
Dr. McGarry, closing thoughts, anything we missed, anything we should have added?
Yeah, I think that it's been an excellent talk. Obviously, our whole goal is anytime obviously we're out there, taking care of athletes, but we're out there on the sidelines. Our whole goal is to try to do everything we can to get those kids back to doing what they love to do, and that's playing sports. But obviously, it's our whole goal too to make sure they're safe. Neck injuries are one significant area of sports medicine that obviously, the potential downside is so catastrophic. I've had one episode in my sports medicine career where I had a kid. I wasn't at the practice, but it was a team I was taking care of, where in a tackling practice, a kid hit somebody and basically broke his neck, and to this day is a quadriplegic. Now that is as sobering an event that you could ever see in any kind of sporting event, and it's something that always makes you think twice. Obviously, our goal is to try to get kids out there playing as safely as possible, but this particular injury branches on to the side of that. Obviously, it's something you can't just take for granted. You can't just take it lightly. It's something that I much rather err on the side of being a little bit too cautious rather than being too cavalier about this, because the downside of this is something that is just completely devastating and catastrophic. So I think there's safe ways to get kids back playing, but I do think this is a particular injury that does bear a little bit more raising of the red flags when you see this, just to make sure that it's something that does check out, that it's not just something trivial, and it's something safely we get those kids back playing.
That was excellent. Thank you. And Bryan, closing thoughts, anything we missed, anything we should have talked about? What can we add to this topic?
No, I mean, the only thing that I think we probably need to add is education. on the side of, again, us educating athletes that this is a serious injury, and can be potentially life-threatening or potentially life-altering. And I can't tell you how many athletes I've had over the course of my career that have told me, I just get stingers. I get them all the time. It's no big deal. And my eyes get, huge, and I go, define that for me, please. What do you mean you get them all the time? How long have you been getting them? And most of the time, the parents don't know. Most of the time, coaches don't know. So again, just getting across the point that, again, this is a serious, can be very serious type of injury.
That was awesome. So everybody, this was great, very informative. We don't hear a whole lot about burners and stingers, even though it's very common. I researched all the podcasts I could find, and I really couldn't find anything that talked about the C5/6 neuropraxia that Dr. McGarry talked about, and treatment and kind of the evaluation. So I think this was, again, very informative with the differential diagnosis, which again is important because some kids are going to come off shaking their arm and they've got a grade 3 AC separation, and the neck's fine, and the brachial plexus is fine. So that's going to happen as well. So from CORA, we thank you, and everybody have a good night. Stay safe, and we'll do this again soon. Thank you.